Okay. Hello, everybody. I'm Giovanni Balato. I'm an assistant professor at Federico II University of Naples. I want to thank MBA for this opportunity and also for organize this webinar on the treatment of periprosthetic joint infection. As you all know, for the treatment is very important to manage this patient with an accurate debridement of infective tissues and also local and systemic antibiotic therapy as suggested by the latest guidelines. So the faculty, I want to thank also the colleagues that are here, is particularly involved in the diagnosis and treatment of local infections. I want to thank Dr. Lydia Morgan-Jones for his presentation and also other colleagues that helped me to handle the discussion. And we have Dr. Pablo Sanz from the Department of Orthopedic and Traumatology of the University Hospital of Madrid, Dr. Tiziana Scione, that is an infectious disease specialist from Naples, from Antonio Cardarelli Hospital of Naples, and Andres Camprodon, that is the chief of a knee unit of the Hospital of Palma de Mallorca. So now it is my pleasure to present you Dr. Lydia Morgan-Jones. It is a consultant orthopedic surgeon at Spire Cardiff Hospital for his talk entitled Infected Total Knee Replacement, How I Do a One-Stage Revision, How Stimulan Improved My Clinical Results in Treating Musculoskeletal Infection. Please, Doctor.
Good evening. Thank you for the introduction and for the invitation. It's a slightly cold and wet day here in Cardiff. I hope it's a little warmer in Europe. I'll share my screen and then I'll start presenting, and I'm happy to answer any questions about the presentation. So this is very much a talk about what I do, and I'll say now there's almost no science in this. This is based on 20 years of treating infected knees, and it'll be a discussion paper, and I'm hoping to be a little bit controversial. I'm hoping to stimulate some debate, and I'd certainly welcome questions at the end. So I want to cover my philosophy, cover the exposure to get in and out of a knee revision, my debridement protocols, it's a little bit about reconstruction, and then finish off talking about antibiotic delivery and how important I think local antibiotics are. And finally, possibly give you some reasons why I wouldn't do a two-stage. So I'm talking about one-stage revision tonight, but anybody who does joint infection work has to be able to do everything, and including one-stage, two-stage, adhere, debride and retain. You have to be comfortable doing an arthrodesis, an amputation, need to know when to stop operating and try and use antibiotic suppression. And key also for surgeons who are not doing high volume is knowing when to stop and refer. And the referral, I think, is the most powerful management option you have. Even if that referral is just to discuss with a colleague and you study the case yourself. Referrals, second opinions are valuable, and I don't think we do them enough. So when I started 20 years ago, I was, like most people, doing a two-stage protocol. But I was doing two-stage in a way that I felt helped patients. So here's an example from a while back now. It's an infected re-revision knee, and we can see we've got a draining sinus here and a failed implant. We've got major bone loss, instability, and infection. And for these cases, a long time ago, I was trying to rebuild the knee in 2 operations. And this is what I was doing. I was putting in a temporary joint, what we called an interval prosthesis. So I was reconstructing badly. I was trying to get the joint line, trying to get a little bit of ligamentous stability, a knee that could weight bear but move and function. And of the cases I did, 40% refused to have the second stage. And this is an example where he went on to unite and heal, and 10 years later, it's still not had his revision for the second stage. So surely, if I'm putting metal and cement and polyethylene in, I was doing a one stage. Even though it was a two-stage protocol, even though I expected to do another operation, in 40% of these cases, I just didn't do it. And so it led me to think about, why am I doing 2 stages and possibly one could be better, even in the complex scenario. And here's philosophy. This isn't science. This is my bias. I think foreign material is foreign material. Whether it's a fully cement spacer or it's this interval prosthesis, this temporary joint with cement and polyethylene and metal, it's all foreign material. So what makes the difference? What makes the difference is knowing how to debride the infected joint. And I'll come on to that shortly about how I use protocols to drive my debridement. So every operation starts with exposure. And again, if you're doing revision knees, you need to be happy to do a very radical extensile exposure. I use sterile tourniquets, single use, that exsanguinate and give me a very big sterile field above my incision. I use a tibial crest osteotomy almost exclusively. And I do it using osteotomes, so it's low energy. I try and keep it along at 6 centimeters. And we break the lateral cortex, but retain the lateral soft tissue hinge. So we open like a book. And that gives us great exposure, but it keeps the osteotomy vascular and stops migration proximally. And because it's vascular, it aids union. So in almost every case I do for infection, I will do an osteotomy. And here's an example where I've done a radical osteotomy, closed it, and I use Ethibond interosseous sutures. And they are full weight bearing and free movement. There is no restriction afterwards. I don't bother about bending, I don't bother about bracing. They can do what they like. They are fully weight bearing, free movement. And this osteotomy does allow you to do that. Exposure allows you to debride. And debridement comes in 3 stages for the surgeon: surgical, chemical, mechanical, and chemical. And you should philosophically try and debride so well that the 1v2 stage argument is irrelevant. You debride so well that if you wanted to, you can do a 1 stage. You choose not to because philosophically that's where you stand. That's absolutely fine. But the debridement should be so good you could, if you want to, do a 1 stage. The reasons why you might not, and we'll come on to that later. So here's the first part. Surgical debridement starts with exposure. Then you explant the metalwork and all the cement and all the debris. You take out any sequestra, any dead bone. You excise the synovium and any biofilm. But you need a radical exposure to be doing that. An explantation for the infected knee is the same as sequestrectomy for the osteomyelitis patient. Here's an example where we have a non-union, an infected implant, and lots of infected sequestra, strut grafting. So taking out the dead bone, the same as taking out the dead and infected metalwork. And you debride back to a sterile field as best you can. And you need to think that your debridement is separate from your reconstruction. If you're worried about how much metal I have to put in, how big the implant is, what's my fixation going to be like, then you might not do the debridement that you need to do. So try and separate in your own mind debridement from reconstruction. And obviously some people will separate that in 2 stages, having 2 operations. I just do that 2 stage very, very quickly. Mechanical debridement starts with curetting the surfaces, and then I remap the intermedullary canals. I use power reamers to take out any dead avascular tissue inside the medulla. Here's an example of having taken out a stem. We've got white avascular bone, and after reaming, you end up with bone that will bleed. If it will bleed, you've got a chance of getting rid of infection. You follow that up with power lavage. So I always use pulse lavage. I don't think using a syringe with your own hand is enough. You want power because you want to get that volume directed to where the infection is. And you also want a tidal effect. You want the power to wash in the fluid and wash out the debris. And lastly, you want the power lavage to create edema in any membrane that's left behind on the bone surface or in the canal. And I believe it's not the quantity, but the precision and focus that's more important. Here's an example where I've explanted the metalwork and I've put a lavage through it, and you can see here there's membrane everywhere. So I've got this biofilm that I've identified and I've made membranous edematous with a power lavage. Because I can see it, I can debride it. Here's the same patient, and now look how clean it is, having done the debridement. I've made the membrane edematous, it's easier to debride. And if it's a big infected re-revision, I might use 3 to 4 litres of saline. I very rarely do more than that because I use it precisely in the lavage in a focused way. I don't think I've ever done more than probably 4 or 5 litres. I don't think it's necessary. That brings you on to chemical debridement. So I've written and lectured on the use of acetic acid quite a bit. So acetic acid is my poison. I use it because it lowers the pH. It makes a chemical environment that's toxic to organisms. The molecular size is low enough to penetrate cell membranes, and it has a broad spectrum activity. But you can choose your own poison: alcohol, beridine, chlorhexidine, Ponstan, hydrogen peroxide. Just think about having a chemical debriding part of your debridement so that the field is sterile before you implant. My current regime has moved on to combination therapy. So for the last few years, I've used hydrogen peroxide plus alcoholic chlorhexidine together. That produces a chemical debridement, and it effervesces, and as a tidal lavage will bring out any debris. And then I'll use acetic acid at 3% to sterilize the field before I reimplant. That's my poison, but you can use other solutions, and I encourage you to work out what you want to use. Let's bring that all together. There are 3 phases of the cyclical debridement: surgical, exposure, explantation, and excision. That leads you on to curettage, reaming, and lavage, which is your mechanical debridement. And that mechanical debridement takes 2 or 3 passes until I'm happy it's as clean as it can be. And then I use a chemical debridement before reconstructing. And the reconstruction may be 1 stage or 2 stage, but each phase, surgical, mechanical, and chemical, is the same up till that point. Let me give you an example. Here's a male, he's 81, he's got an infected knee replacement. You can see here the condition of the skin. You can see the infected synovium and biofilm inside. If you look at the X-ray, you can see these granulomata that are features for infection. What do? Well, look, we do an explantation. We correct the biofilm out. We ream out the canals. Then we lavage and repeat the process. That's the schematic. That's what I'm trying to do when I'm debriding. Then we do a chemical phase before we do a reconstruction. The reconstruction here is using sleeves and stems for fixation, cement to plug the dead space, and I've gone for a mobile bearing constraint. Had you done this in 2 stages, it's fine. That isn't the argument. It's about debriding so well you can choose 1 or 2 stages. Reconstruction, I have no bias as to whether you use uncemented or cemented fixation. Uncemented and cemented fixation is a means of fixing your implant to the bone. Whether you're revising for infection or instability or loosening is irrelevant. You achieve good fixation using the correct implants. And the level of constraint is based on the level of instability, what hinges you have, sorry, what ligaments are residual. So I do not cut out ligaments because it's infected. I debride the ligaments. And almost exclusively, you can then retain the ligaments and you do not need to use a hinge. I have no problem with using hinges. I have no problem using cemented implants, but it's not essential. Let me give you another case to drive that home. So this is a 76-year-old woman, failed infected revision knee replacement, got bone loss, we've got poor fixation, we've got sinuses, it's an MRSA infection. We debride and we reconstruct, and here it's a fully uncemented fixation. This is going back a few years now. I may have done things a little bit differently now. I might have gone for a distal femur, but I was using reconstruction purely a few years back. This is the post-op X-ray. Here's the 8-year review where we've got reconstruction of the bone. It's grown back again. It's grown back behind the implant. So bone is regenerated because I've got good fixation and I've got physiological loading. Debriding is what gets rid of the infection. And that is these X-rays were taken 8 years after implantation. The lady is now 4 years beyond that. Which brings us on to antibiotics. If anybody's heard me talk before about infection, I use these two quotes. Vanya Gant is a microbiologist at University College London, and he says that antibiotics will make a third-rate surgeon into a second-rate one, but will never make you a first-rate one. And what he's saying is that you must debride to give antibiotics a chance. If you debride poorly, if you do not clear the infection surgically, antibiotics will not help you. They will not get you out of trouble. And my second favorite quote is from Professor Bertazzoni from Verona, who colourfully says, antibiotics without debridement is like deodorant without showering. It may smell good, but you still haven't cleaned it properly. But you get the picture. So antibiotics, and this is a surgeon's guide, my view of antibiotics, and I've got the 5 Ds. Diagnosis. Have I got the organism? Do I have the sensitivities? Am I using the right dose? And I think historically as a surgeon, I've underdosed. Duration, long versus short course. I try and go short course IV, early conversion to oral whenever I can. Duality. There's almost no time when I use monotherapy. I'll always try and use combination therapies to tackle the same organism. Then delivery. Systemic versus oral, well, actually both. I'll use systemic, short IV, longer oral, but I'll always use local antibiotics. These are the 5 Ds that I work with, but I always do it in combination with a microbiologist. So every infection case will go through an MDT. We'll discuss the organisms, the sensitivities, we'll discuss the complexity of the case, and then we'll debate which antibiotics to use, 1 versus 2 stage, and so forth, but always in discussion with a microbiologist. So for most infected cases, this is the protocol we go for. It'll be teicoplanin and meropenem, give us a broad spectrum for the first 5 to 7 days until we get the first intraoperative cultures back. If intraoperative cultures match preoperative cultures, we'll change to possibly a slightly narrow field, but always dual therapy. And if they're fit for discharge, that's when I'll stop the IVs and convert to orals. So if they're fit to go home day 7, I'll convert then. If it's day 10, day 14, when they're fit to go home, I'll then convert to orals so they can go home earlier. The exceptions will be local conditions. So in South Wales, we have some very resistant gram-negative organisms, and we have a whole host of multiple drug-resistant organisms, a lot of vancomycin-resistant enterococcus in South Wales. So they might be the exception where we go for longer IV therapy. And that's where having a microbiologist on board is very, very helpful. So what about local antibiotics? There was a time when I used no local antibiotics and I could get 90% clearance. But I want now, by having the same debridement protocols, the same parenteral IV oral antibiotics, but adding in local antibiotics, is hoping to move up from maybe 90% to 95% success rate. by having local as well as systemic therapy. The local antibiotics give you much higher concentrations where you need them. Local antibiotics will avoid the systemic toxicity of IVs. You get much different exposure of commensal flora to IV antibiotics. So antibiotics you give IV don't just go to the limb, they go everywhere. You get resistance for that, you'll get C. diff from that. So I think IV antibiotics, systemic antibiotics, I'm trying to use less and less and for shorter periods and use more and more local therapy. I choose to use STIMULAN, a properly bioabsorbable calcium sulfate. It allows me to use the antimicrobial of choice, what I need to use locally in combination. And sometimes I'll use different combinations locally to systemic. So I might use vancomycin and gentamicin in the STIMULAN, teicoplanin and meropenem systemically. It gives me higher concentrations and extended local delivery. And this is truly bioabsorbable. And I've used some of the comparative calcium sulfates out there and they do not bioabsorb the same. MBEC, minimum biofilm eradication concentration. That's the holy grail for the infection surgeon. Can I get antibiotics locally at such a concentration that even when I leave a little bit of infection behind? Because despite what I tell you about debridement, I can't tell you it's sterile. I'll try my best. I debride extensively, but I must be leaving an organism behind. A little bit of biofilm, I must be. So does the local antibiotics allow me to break down that biofilm if I get concentrations that are thousands of times higher locally by local delivery that I can use, that I can give by IV therapy? Here's an example where I use it at the reconstruction, both inside the bone, but also inside the joint. Because I know the purity here will allow me to put it in the articulation without damaging the bearing surface. One of the innovations recently is an intramedullary delivery. And I've started using this delivery system to get antibiotics inside the bone. We're very good at doing it in the joint, a little bit into the bone, but I need to get it further into the bone at times. Here's a case of intermedullary osteomyelitis after nailing. You can see the changes in the bone here and here, and the MRI shows activity all the way through the bone. So we debride, reaming out the canal, and then introducing calcium sulfate beads all the way up the canal. And we know that will deliver antibiotics where I need it. We know that will bioabsorb. Here's the 3-month x-rays where we've got eradication of the cavities in the bone and all the biofilm is gone. And I'll use this commonly with antibiotic delivery in intermedullary osteomyelitis. I'm starting to think about using it into the canals in the re-revisions where I know there's infection above and below my infected implant. So I've shown you a lot of one stage that I will do. Because as I said at the start, you can't do one stage in everybody. And even though my threshold may be different to most, there are still cases I will not do 2-stage. For example, here, where I have no skin and I need to use a gastroc flap, I raise myself to close. The soft tissues are so poor before you start that you run the risk of poor wound healing. So they'll get a 2-stage with a static spacer. No infection, elderly patient. So infection, elderly patient, no extensors. That'll be an arthrodesis in my hands. So that'll be a 2-stage static spacer. And then if I'm doing massive resection for chronic osteomyelitis, it'll be a 2-stage. Here's an example, 66-year-old female, quite young, two months after a 1-stage revision for aseptic loosening. It's not infected, it's been an aseptic revision. But this is how it presents. 2 months after a routine, straightforward revision operation, but done by a surgeon who's not doing many revisions. If you remember back at the start, I gave you those 7 options, and I said the most powerful was referral. Here's an example. Good surgeon, but doing an operation he didn't do many of. He's had complications. So this was avoidable. Now we're into salvage. How do we salvage? We go for fusion over a static spacer, antibiotics inside the canal, inside the cavity, and a gastrocnemius flap raised to cover the implant, cover the space, cover the defect. Then go on to clear the infection. You've got skin grafting of the defect. And we now have a limb that is salvaged, that is weight bearing, that has not gone on to amputation. But I'm not going to re-revise that. I've got no extensions. I got limb I've salvaged. The risk of re-revising, I think, is extensive. So this is my 2-stage. So I've given you a lot of bias, a lot of philosophy, very little surgery, although I have published on all aspects of the work I've done, and if you care to Google my outcome data, you'll find it's all out there. But if I give you one slide that helps you, let's look at 1 versus 2 stage. So 1 stage, pick winners, pick healthy A and B hosts, pick a good organism where you've got sensitivities and you know you can clear and debride. I don't think no organism is a counterindication to 1 stage, but some people would say so. I don't think sinuses are an absolute contraindication, but some surgeons would avoid it. If it's a nice, simple, infected primary knee, you've got every chance of success with 1 stage. If it's a compromised host, a bad organism, and it's a multi-revised knee, probably you should do 2 stage. Certainly, you should refer and get a second opinion. But whatever you do, remember that debridement is the key. Debridement allows antibiotics to work for you. Antibiotics will help you if you debride well. If you debride well, you can choose to do 1 stage or 2 stage. I hope that's made sense. Thank you for your time, and I'll happily take any questions.
Okay, thank you very much. Okay, it's a very interesting presentation. Thank you very much. So we start with discussion. We have only 2 questions from the audience. I read now. One is when you remove an infected megaprosthesis, which method is better for obtaining stability? For example, a big piece of cement alone, or with STIMULAN, or external fixation?
So I have an external fixation background, but I've moved away from that because it is difficult for the patient. And I think with modern implants, you can, if it's a short defect, say 8 to 10 centimeters, you can use a tibial nail, a femoral nail, or some Hoffman bars covered in cement to give you a reinforced static spacer. If you're doing a big defect up to 10 to 20 centimeters, I tend to use an arthrodesis nail, and I use the again, you can use a femoral nail. Problem with femoral nails is then the explantation. So I use a link arthrodesis nail because I can bring it together, screw the fixation, cover in cement, but when I explant, you take the screws out and it's a lot easier. I tend to use uncemented in the canals, but with local antibiotic delivery with STIMULAN, but I coat the spacer part of it with cement, which will then add to the stability at the bone interface and increase the likelihood of weight bearing. Because between stage 1 and 2, if you've got a stiff leg, you want them to at least walk on it. So yeah, look, it depends. I don't know what you use, but it depends on the size of the defect. Okay. If you're going to put just cement, put a static spacer with reinforced concrete. Very small defects with good ligaments, you can put an articulating spacer. Sadly, it's been many years since I was referred a knee that I could just put an articulating spacer in. And these days, if I'm referred somebody with a good ligaments, simple primary, I'm going to do a 1 stage.
Okay. The second question, in the preoperative planning for a revision, do you always take in account to do a synovial fluid culture and the leukocyte count?
Yeah. So it's a struggle, I'll be honest, in my hospital to get that. And I've been trying for years to get it routine. So we have to do it on a case-by-case basis. And we are getting to the point where it'll become normal for my aspiration to have white cell counts and culture. I'm lucky in the sense that most of my practice is tertiary referral. So we know it's infected. So the question, is it infected, is it not infected, is very rarely a problem for me. What I'm interested in is the organism. Because when you're dealing with a re-revision, somebody's had a 2-stage, it's still infected, and they've had a course of antibiotics, and it's not worked, then the flora, the organisms will change. And even if it's the same organism, you may now have a resistant organism. So recently I had a patient who had a DARE elsewhere, but the DARE was just a washout. They hadn't done a proper debridement, and the staph was the same staph, but now it was resistant to rifampicin and several other organisms. So it meant that my choices afterwards were to go to much longer IV therapy than I would do for the complexity, because I now had resistance. So for me, look, every case will be aspirated because I want to know the organism. If I'm really worried that it's not infected, but I'm concerned, it'll be aspiration plus a white cell count, maybe a synovasure. But I don't do many synovasures these days.
Okay, thank you. So we have also other question from Dr. Sanz, Pablo Sanz.
Be kind.
Thank you, Ryan. You know, it's a big pleasure to hear you. Just a couple of questions about the use of local therapy. The first question is, in the normal case, normal situation from primary, how much stimulant do you recommend to use? This is the first one. The second one, when you use a cemented implant plus stimulant, do you recommend to use the same antibiotic in cement and stimulant? Or do you prefer to change? For example, use vancomycin in bone cement and daptomycin and stimulant. And finally, sorry, in the case when you have a prolonged drain managed in the 5-6 days after surgery, but do you use a stimulant? Do you feel safe because in theory these liquids have a lot of antibiotic, or do you can to the OR like a normal prolonged drain?
Okay, so I'll go in reverse order. So drainage is an issue that you will see in a percentage. When I first started using Stimulan many years ago, it was a real issue for me, drainage, but I was using it in the worst possible cases. They were the salvage cases, and I was throwing everything at them. I was learning to use it. And these cases, I showed a couple of examples where, you know, we had open wounds, and with the best will in the world, even if you put a gastric flap on, you can't get sealed closure. So I was having more drainage than I was comfortable with. But the answer was for me to work harder on my closure. So, you know, I would do more gastric flaps. I would do more gastric flaps plus immediate skin grafting. I would then put a plaster slab on to reduce movement early on. Even if I put a hinge in there, the skin is very bad, I'd rest them in extension for the first week. So I was really concentrating on getting the skin closure and the skin healing. And in cases, you just have to. You just have to really be meticulous with your deep closure, your subcutaneous closure, your skin closure. And then if in doubt, just rest them in extension. Don't worry about the bend. Your primary goal is skin healing. Latterly, I'll be using a lot of barbed sutures, and I think that's made a difference. So I do barbed sutures. I might add a bit of glue in the skin as well. There's lots of ways to try and get watertight closure if you can. But you will still get a little bit of drainage. If you do, put them in bed, put them in a brace, put a front slab on, take them out of walking and bending for a week. Just rest them. Give them foot pumps, give them some Clexin. You know, they won't get a DVT. They will not be stiff in the long run for the first week. But healing is important. Then you asked me about quantity. So I tend to go for 10 mils as my baseline. And if I'm doing some Stimulan in the joint and in the canals, it'll probably up at 20 mils. So I got 10 mils, 5 mils in the femur, 5 mils in the tibia, 10 mils in the joint is about my go-to. I rarely go beyond 20 mils. Now, I know I have colleagues who will routinely put 30 mils in. The problem is we don't have the data that says 30 mils is better than 10 mils. You'll definitely get more antibiotics in there, but you might also get more drainage. And if you're doing a 1-stage or a 2-stage and you're putting a spacer in there, then actually closing is an issue. And if you put 30 mils of calcium sulfate in it, that's a lot of volume, and closure can be an issue. So I think that's something to bear in mind. in terms of which antibiotics, I mean, that's really one of the big advantages of STIMULAN. So you can use different antibiotics in your cement to your STIMULAN, or you can use the same. So if we've got a simple organism, it might still be Vancomycin Gent in my cement, and it might still be Vancomycin Gent in my STIMULAN, because we know what the organism is. And Vancomycin Gent gives you quite a big spectrum. If you add in Ticumplanin and Meropenem IV, really big spectrum. The real advantage is if you've got multiple organisms. And I see a huge advantage if you have cases I treat where there may be 2 different bacteria, gram-positive or gram-negative, resistance, and you've got a fungus infection. So what we'll often do is have antibiotics in the cement for the bacteria, and I'll do 2 separate mixes of STIMULAN, one for bacteria, one for fungi. So I know I'm going to get high-dose local antifungal therapy into the joint, and I can be, again, broad spectrum in terms of STIMULAN antibiotics and cement antibiotics. So you can really tailor your therapy to what you're treating on table. And then, you know, you wait for your samples to come back, and sometimes it's a best guess, and you're waiting to know, did you use the right ones? And sometimes you've got the right therapy locally, but you still need further IV therapy. Did that answer everything?
Sure.
Okay, another question from the audience. For the implement of tibial sleeves, it is necessary to cover with cement the part of the sleeve, or we can just leave it uncovered?
Yes, so sleeves are designed to be uncemented. And if you stand back from the infection world, if you're putting sleeves in there because you're reconstructing and getting good fixation, then there's no indication to use cement. You know, the sleeve alone, plus or minus a stem, and mostly I use stems, will give you good fixation and reconstruction in zone 2, the metaphysis. But every implant has a limit. And I've certainly had cases where I've gone in to put a sleeve in and the bone is too big. It's bigger than the biggest sleeve on either the tibia or the femur. Or at the biggest sleeve, the bone quality isn't good enough. And if that's the case, then I will down the size of the sleeve and use it as a cemented implant. But if I'm doing that, then it'll either be a hybrid fixation with a bigger stem, so the stem works harder because you want a little bit of initial fixation, or it'll be a shorter stem but fully cemented sleeve stem construct. But I regularly will put a sleeve in that does not have 100% bone interface, and you need about 60 to 70% three-dimensionally, top to bottom, all the way around, plus a stem. So the bigger the defect, the more the stem works. In cement, I will use, in the infected case, then I'll plug any defect behind the femoral condyles down to where the sleeve is, and underneath the tray down to where the sleeve is with cement to plug dead space. But I'll try not to put it too low. I know there's a case that had cement and sleeves. That was dead space management, not adding to fixation.
Okay, I have 2 more questions. One is, I believe, is a consideration at the beginning. I believe in chemical debridement. So I use another mixture of antiseptic.
Yeah.
Okay, I use betadine, iodine, and peroxide.
Yeah.
And recently, this combination is described as the best solution. What do you think about the use of betadine and peroxide instead of acetic acid?
Oh, well, obviously I'm right and you're wrong. Yeah, obviously. Yeah. No, look, I stumbled upon acetic acid back in 2015-16. I did some collaborative work with Professor Kirkup Mollers from Copenhagen. And acetic acid is used a lot in the wound healing world to debride predominantly Pseudomonas. So it's got a pedigree going back thousands of years. So I started using that as I was building this chemical debridement protocol I was using. But I use hydrogen peroxide. I use clexidine, alcoholic clexidine. Beridine works, chlorhexidine works, hydrogen peroxide works, Ponstan works, acetic acid works. I think the important thing is you use combinations, not one thing or the other. But I use alcoholic chlorhexidine, and I think that's more effective than non-alcoholic chlorhexidine. Now, people worry about alcohol affecting wound healing. Well, you know, I take a hammer and a chisel to my knees, you know. That's far more destructive to wound healing than a little bit of acetic acid and a little bit of alcohol. And people would say, you know, don't do it. You should come and see me operate. How anything I operate on heals, I have no idea.
Okay, the second question is, recently I read about 1.5 revision.
Yeah.
What do you think about?
So I was a little miffed at this, okay, because this came from America, and I'd written exactly the same paper and published back in 2013. What they were describing was the interval prosthesis that I did, okay, and what the Exeter crowd subsequently called a kiwi hip. And again, I was doing this 10 years before Exeter were. All they're doing is putting in a badly cemented implant, hoping never to go back. And that's what they're doing. But what they are doing is constructing the joint line. And in the knee, you know, if you can balance the ligaments, then you can get a function. And if you cement in reasonably well, not going crazy with big stems and big sleeves, then in most cases, you know, that simple cement technique will work. And my original series, we've just reviewed them, and of the cases, the 40% that I did not go back and do the second stage on, 90% of those are still going, and we're out at minimum 13 years now. Okay, so it does work. I submitted that paper to the Bone and Joint Journal, and they rejected me. Okay, 9 years after I published my paper, I had to review that paper for the journal, and I said yes, publish it. Okay. So look, it's old news. It's old news, but because it comes from America, everybody sings and dances to it. It's old news. Yes, it works. Okay. I'm not bitter. I'm not bitter.
Okay, okay. Now I have some question from Dottoressa Schule.
Hello.
Good evening. Good evening. You said that you always perform an aspiration before operation. When you have a culture negative, you change your planning?
Again, I'll be controversial and say no. There's increasing data available that the culture negative infected knees and hips have as good, if not better, outcomes than when you grow something. And the worry is you've got a really horrible bug that you can't grow. Most of the time, what you've got is an organism that is low virulence and has been partially treated by antibiotics before, and maybe you've got some sampling error. So I've looked at my one-stage series, and all the culture negative patients have done well. We've had no re-revisions, and we're publishing that data this quarter. That doesn't mean you shouldn't try. And you know, if I get a negative aspiration, I might repeat that aspiration, or I might do an arthroscopic biopsy. Most of the time, though, in my practice, it's obvious there's an infection. You just need the organism. And if you think about it, what does it change? Well, if you've got no organism and no sensitivities beforehand, what you need to do is broaden the spectrum of the antibiotics. You need to cover everything. So you might use broad spectrum local antibiotics, broad spectrum systemic antibiotics, and you keep them going until your intraoperative samples come back. And it may be you will not grow anything to take the implants out and take the membrane from behind the implants and inside the bone. That's where you get your greatest yield. Why do we say you can't do one stage in infected revision? That stems from one unit, the endoclinic in Hamburg. And that stems from one microbiologist who is a brilliant, brilliant microbiologist who is right in everything he says, except this. The way the endoclinic works is that you get a one stage when you have the organism, because if you have the organism, you know which antibiotics to put in your cement. It's that way around. I would argue that if you started from a different place, then if you understood that the outcome's the same whether you have an organism or no organism, if you understand that it's the debridement that's more important, and that if you go for broad spectrum coverage, you're going to get the same outcomes. You need not worry about doing one stage without an organism. Okay, I will happily do one stage when I have no organism. My exclusions are what I've shown you. No organism isn't part of it. Controversial, I know. Biased, yes.
Yes. And then when you use stimulan during operation, do you think that you can reduce the time of antibiotic system after operation?
Well, I mean, certainly there's been a vogue in the UK, and the Viva study, would back us going from IV to oral early, and certainly decreasing the amount of IV therapy we give. And I've always done that. I've always gone short course, but I have even more confidence now because I know that stimulan will be in that knee joint in the infected field for 6, 8, sometimes 10 weeks, depending how much I put in and where I put it. So having that extended local coverage, yes, it gives me a lot more confidence. And when you've got a more complex case where maybe you have to go longer because it's a gram-negative and multi-resistant, you know that there's dual therapy here. There's intravenous, there's oral, there's systemic. There's local antibiotics. So you have greater confidence when you stop. See, after 6 weeks, there's still a bit of coverage internally that will protect you.
Okay. In the post-operative persistent wound drainage, how many days you wait until make a debridement? And if you use stimulan in those cases?
Yeah, so there's a difference between a primary knee, immediate post-op drainage that fails to settle. Firstly, that's a very rare occasion. And, I'm a fairly aggressive in non-surgical management. So if they're still draining at day 1, day 2, I just leave them in bed. I stop the physios going around. I rest them. I keep them in extension. I tell them not to worry about them. I don't worry about ERAS and early discharge. I just slow them down. And more often than not, it settles. If there is proper persistent drainage at 7 days, they go back to theatre and they have a debridement, including poly exchange. So 7 days is my cutoff. But honestly, it's been years since I had to do that. With the revisions, the stimulan, I'm a little bit more relaxed because I know it's a big operation. I know the wound is going to leak more. But with them, I start off by slowing them down. I don't wait until there's a problem. I deliberately, post-operatively plan for more bed rest, less movement for the first 5 to 7 days if I'm worried about the wound. If the wound closes well, easily, I treat them like a primary.
Okay. We have no more questions. Something else? Pablo.
Vivian, one practical question. In one external revision with the stimulant, do you prefer to use the small pierce to obtain a high peak, or do you prefer the big one to have more time of antibiotic?
That's a really good question. Really good question. I would prefer to have the bigger beads that elute for longer because it's not the only mode of giving antibiotics. Sometimes I use smaller beads. If I do an osteomyelitis, for example, rather than a prosthetic joint, then the smaller beads allow you to pack in better around the corners. If I'm honest, by the time I ask the nurse to mix the stimulant, she's already done it, and she's chosen which size they are. Because before we've already worked out which antibiotics they know beforehand, and the nurses are so keen to get on with it. They've done it, and I've scrubbed, walked in, and there it is ready, and they've chosen for me. But if they ask me, it'll be the slightly bigger beads.
Thank you.
Okay. Do you use disclosing agent to guide the mechanical debridement, like a methylene blue or something else?
No, that's a really good question. Part of my training was in Johannesburg with a surgeon called Charles Lautenbach. And Charles he passed away a couple of years ago. But he had the biggest single surgeon experience in the world. And I don't think it'll ever be beaten. You know, when I was with him 20 years ago, he'd done 7,000 cases of infection. And by the time he retired, well, in fact, he never retired. He died, you know, 2 weeks after his last operation. So he must have been, you know, 15,000 plus as one surgeon. But he would always use methylene blue, and he'd inject it in the sinus, and he'd be meticulous about excising the tract and following it and debriding everything. I did that a little bit in my early days. I don't find it too helpful. You know, I do a radical synovectomy, and then I use that pulse lavage to show me any membrane left behind. It's very effective at making a small bit of biofilm edematous, so you can see it. And then the other trick I use is to turn the lights off. Yeah. You find theatre lights produce a lot of glare, and I think if you turn the lights off when you're debriding, you'll actually find the bone surfaces is much easier to get sense of depth and perception. The lights just make it much, much brighter. So turn the lights off. I never use lights anyway, but one trick is when you think you've done enough, turn the lights off for 5 minutes and then have a good look. You might find a bit more. And then the other thing that I'm looking at the moment is a, one second. I'm going to do some advertising. Moleculite. That belongs to Smith & Nephew. And I'm trying, it's a free sample. So, it's a violet light system. Like it's an iPhone basically with a violet light attachment. And we're trialing it now at the start, the middle, at the end of the debridement to see how many organisms biofilm have gone. And the problem is you have to be in a really dark theatre to take it. So we're just trialing it, and it may be of value. It may not, but certainly the next time I do a talk, I might throw some violet slides in there to show you good and bad debridement.
Okay, any question from the audience? No.
But I think that, you know, I think the message I want to leave everybody is one, that debridement is so important, but also second opinions, referrals, talk to colleagues. I'm learning all the time, and you know, the questions about tonight have made me stop and think a little bit about my practice. So if you're doing a small revision practice and see very few infections, pass them on. They're hard work. Go to bed early. Go and have a glass of vino. Yeah? Let somebody else have the late night and the hard work. Yeah? Top tip.
Okay. We can close. I don't know if we have finished.
Yes, there is no further questions from the audience.
Are there any questions from MBA or from biocomposites or anybody else? I'm happy to answer any questions.
May I do a question myself?
Yes, of course.
Yes, it's regarding the question from Dr. Astiane and in the cases when you have a negative culture. Do you think, do you think it would be a good option to have a diagnostic test that can rule out the presence of infection?
Yeah, no, absolutely. And again, you know, I have to be careful that my practice is very different. You know, people come to me with infected knees. You know, that's why I treat them. So when you've got a sinus, when you've got multiple previous sensitivities, you know, you've got classical X-ray changes and a big hot swollen knee, you know it's infected. What's important is the organism. Mm-hmm. So I concentrate far more on getting the organism. I do multiple aspirations, I do arthroscopies. If I get patient referred in, we always make sure the microbiology comes with them. You know, so I know what the organisms have been, what antibiotics have been used. So we try and work out why it didn't help. If you're in doubt, don't rush. You know, repeat the bloods, repeat the X-rays, repeat the aspiration, do an endoscopic biopsy, get a second opinion, use Synovasure. Unfortunately, there's no 100% test out there, and often it's accumulating knowledge of the patient, get a bit of information from each test and putting it together. But what difference does it make? You know, if you haven't got an organism, debride as if you have. If you haven't got an organism, debride and sample as if it's infected. Do the same sampling protocols for everybody. Keep them on antibiotics until the intraoperative cultures come back, and extend if you think it was infected clinically, and then you grow something. Not having an organism is very rarely, in my situation, a cause of concern. But then I do one stage. If you're worried about should I do a 2-stage because it's infected, that's different, because it will significantly affect how you manage the patient. If you have a 1-stage protocol, it makes very little difference to your management.
Okay.
But that's not saying do 1 stage.
And Dr. Barato, there is another question from the audience, if you want to read it. Can you see it, or?
Yeah, a question from Canada.
Yeah.
How are you guys doing over there? So I have, on a couple of occasions, used it in non-infected cases. We've all got cases that are high risk. You're doing a primary knee, or you're doing an aseptic revision, but in really bad skin, poor host. So, you know, you have people with renal disease and liver disease, and you're alcoholics, and people who've got bad teeth, and people with bad skin, but they've got a loose implant, and you know you have to do it, and you've optimized them as best you can. So how else can you protect that implant? And I have, when needed to, used STIMULAN in a paste form to smear over the implant, both stems inside the canal and then beads inside the articulation. So use it as an antibiotic coating. So that's when I would use it as a smear. Similarly, if I'm doing a complex trauma case and I want to put an implant in, then I might smear the nail or something like that. So that's an option. But for the infected cases, I tend to pack as many beads I can into the canal, and then I'm happy with it.
Okay, thank you. So, Dr. Barato, we have no further questions if you want to conclude.
Thank you very much. Thank you, Dr. Morgan-Jones, for your important messages. Thank you, the faculty, and my colleagues for the roundtable. And we can close the section and the webinar.
Thank you
very much, MBA.
Bye-bye.
Bye. See you in Madrid soon.
Okay.
I hope.
Me too.
Bye. Thank you.
Bye-bye.